to the Therapeutics Chronicles. I'm your host, Mu'min, and I'm so glad you are here with me today. Whether you are on your way to work, wrapping up a busy day at the pharmacy, or just looking to sharpen your clinical skills, you have come to the right place. Today, we are breaking down a drug that's practically a household name in lipid management, Rosuvastatin. We will simplify its key details, share practical tips, and sprinkle in some clinical pearls. So let's dive in. And before I forget, do not miss out on future episodes. Subscribe, share this podcast with your colleagues, and send me your questions or feedback at thetherapeuticschronicles@gmail.com. And if you are taking any board exams, please join us in our Telegram group and WhatsApp groups. Let's get started. Rosuvastatin is a statin we use to tackle high cholesterol. It works by blocking HMG-CoA reductase, an enzyme that helps the liver make cholesterol. By slowing down this process, it reduces LDL, the bad cholesterol, raises HDL, the good cholesterol, and lowers triglycerides. So why target this enzyme? Because cholesterol production in the liver is a major contributor to overall cholesterol levels. When we control it, we are reducing the risk of heart attacks and strokes. That's what makes it such an important tool in our practice. Rosuvastatin's potency also sets it apart from other statins, allowing us to achieve substantial LDL reductions with relatively lower doses. Here is how it moves through the body. Rosuvastatin is absorbed in the gut, and it reaches peak levels in about 3 to 5 hours. Only 20% of it is bioavailable. But that's okay because most of it goes straight to the liver where it is needed. It is metabolized minimally through CYP2C9, which means fewer drug interactions compared to some other statins. The rest is excreted through feces. This makes it a solid option for patients who might be on multiple medications. Plus, its limited CYP metabolism allows us to use it confidently alongside other drugs, minimizing concerns about significant interactions. When should we use it? Rosuvastatin is approved for conditions like high LDL cholesterol, mixed dyslipidemia, and preventing cardiovascular disease in patients at high risk. It is also great for slowing down atherosclerosis progression. We also sometimes see it used off-label for things like nephrotic syndrome when managing cholesterol levels gets tricky. These indications are backed by robust clinical evidence showing significant benefits in reducing cardiovascular events. For example, the Jupiter trial demonstrated that even patients with normal LDL levels but elevated C-reactive protein benefited from Rosuvastatin, emphasizing its role in reducing inflammation alongside lipid control. Now let's talk dosing. Most patients start at 10 mg once daily, but for severe cases, doses up to 40 mg might be needed. In patients with renal issues, we typically keep the dose at 5 mg or 10 mg to avoid side effects. Why is this important? Patients with impaired renal function are at higher risk of adverse effects like myopathy, so we need to balance efficacy with safety. It is a once daily medication that can be taken with or without food. Super simple, but consistent timing is key to keep the levels steady and ensure it works as effectively as possible. Encourage patients to incorporate it into their routine, like taking it at bedtime, to improve adherence. What about side effects? The most common ones are muscle pain and headaches, which are usually dose-related and manageable. Rarely you might see rhabdomyolysis or liver enzyme elevation, which is why monitoring is so critical. For example, if a patient reports muscle weakness or dark urine, that's a red flag for rhabdomyolysis. Time to check those CK levels. Routine liver function tests are also a must, especially when starting or adjusting doses. Another point to watch for is the potential for new onset diabetes. Although rare, it's more likely in patients already at risk, like those with metabolic syndrome. This risk, however, is far outweighed by the cardiovascular benefits in high-risk population. Let's cover interactions. Why Rosuvastatin has fewer interactions? Thanks to its minimal CYP metabolism, it is not entirely interaction-free. Antacids containing aluminum or magnesium can lower its absorption. Make sure patients separate these by at least 2 hours. Combining it with fibrates or niacin can increase the risk of muscle issues. So always weigh the risks and benefits. Alcohol consumption should be moderated to avoid adding extra stress on the liver. For patients on medications like warfarin, be cautious. Rosuvastatin can slightly increase INR. So regular monitoring is advised during dose adjustment. Monitoring is straightforward. regular lipid panels to ensure efficacy, and liver function tests to catch any potential issues. For patients with muscle pain, checking CK levels can help rule out serious complications. And in case of overdose, supportive care is the way to go since there is no antidote. Keep an eye out for symptoms like severe muscle pain or weakness. The goal is always early identification of problems to allow for timely intervention and dose adjustments. Let's walk through a few cases. Case 1. A 58-year-old male with type 2 diabetes is on rosuvastatin 20 mg daily and develops mild muscle pain. His CK levels are slightly elevated, so we reduce his dose to 10 mg and the symptoms resolve. This shows the importance of individualizing therapy. Not every patient needs high doses to achieve their lipid goals. Case 2. A 72-year-old female with stage 3 chronic kidney disease is prescribed 40 mg daily, a dose that's too high for her renal function. We adjust it to 5 mg and she achieves her lipid goals without any side effect. This highlights the importance of renal dose adjustments to ensure safety. Case 3. A 50-year-old patient takes rosuvastatin alongside a magnesium antacid and is not seeing the expected LDL drop. Spacing the doses by 2 hours solves the problem. Practical, real-world fixes. Before we wrap up, here are a few clinical pearls to keep in mind. First, if a patient does not hit their LDL target on 40 mg of rosuvastatin, adding ezetimibe is more effective and safer than increasing the dose further. Ezetimibe works by reducing cholesterol absorption in the gut, complementing the action of rosuvastatin. Second, monitor for a new onset diabetes in at-risk patients, as early detection allows for proactive management. Lastly, not all muscle pain is statin related. Check for other causes like hypothyroidism or vitamin D deficiency before stopping therapy. Discontinuing a statin unnecessarily could deprive patients of significant cardiovascular benefits. Alright, rapid fire Q&A time. Let's review some key points. What enzyme does rosuvastatin inhibit? HMG-CoA reductase. How is it metabolized? Minimally through CYP2C9. Can it be taken with food? Yes, it can. What about antacids? Space them out by at least 2 hours to avoid reduced absorption. And finally, what is a critical red flag to monitor for? Unexplained muscle pain or dark urine, which could indicate rhabdomyolysis. And that's a wrap for today's episode of the Therapeutics Chronicles. I hope this practical approach to rosuvastatin gives you useful insights for your practice. Do not forget to subscribe, share this episode with your colleagues, and send your feedback to the Therapeutics Chronicles at gmail.com. And if you are studying for board exams, join our Telegram and WhatsApp groups. If you want to connect with me personally, you can find me on LinkedIn at Mu'min Wali. Stay curious, keep learning, and continue making a difference in patients' care. Until next time, this is Mu'min Wali signing off. Take care.